Welcome to another episode of Inside Your Miami Medicine. I'm your host, Andy Ford, the Dean and Chief Academic Officer of the University of Miami Leonard M. Miller School of Medicine. Today, I am thrilled to welcome to our program Dr. James Weinstein, Senior Vice President of Microsoft Healthcare. Dr. Weinstein is an internationally renowned spine surgeon and researcher with over $70 million in federal funding and more than 325 peer-reviewed publications. A former CEO and president of Dartmouth Health, Dr. Weinstein pioneered the concept of informed choice in neural-informed consent, empowering patients to actively participate in treatment decisions. He founded the nation's first Center for Shared Decision-Making at Dartmouth Hitchcock Medical Center, and he also created and advanced the use of patient-reported outcomes measures, or PROMs, which remains central to value-based healthcare today. During the pandemic, Dr. Weinstein worked with Operation Warp Speed in various organizations around the world, including the WHO and CDC, as well as state and local governments. He has served as a health strategy advisor for 3 presidents, worked on the Affordable Care Act, and helped establish the Center for Medicare and Medicaid Innovation. He was nominated by President Obama as an advisor to the VA system. Dr. Weinstein is a member of the National Academy of Medicine and has advised Congress, contributed to the Gates Venture Fund, and participated in the World Economic Forum. Author of the book Unraveled: Prescriptions to Repair a Broken Healthcare System, Dr. Weinstein's contributions continue to have a lasting impact on healthcare both in the U.S. and globally. Dr. Weinstein, what a pleasure and a privilege to welcome you to the podcast today.
I'm so honored to be here. Thank you so much.
To be. There's so much to talk about today, so I'm just going to delve in. Normally, I would want you to tell us a little about your path, how you get to where you are, but given your broad accomplishments, we might be until tomorrow. So let's jump right into it. So a recurring theme throughout your extraordinary career has been your laser focus on doing what is best for patients and creating systems that serve them effectively. Can you tell us about the origin of this commitment and your philosophy on healthcare delivery?
Sure. Well, I think that as you go into medicine as a medical student or a young doctor, we're pretty altruistic. We go into it thinking we just want to help people. In my particular case, we lost our first child at age 12 from leukemia. She was diagnosed at 15 months of age, and my wife and I, of course, like any family, were devastated by that. She went through 5 relapses. She was denied a transplant. And I had to fight with the insurance companies.
What was she denied?
I think at the time, things with CAR T-cell treatment weren't quite where they were going to be. I had to go to this. And in fact, they weren't offered in Iowa. I was at the University of Iowa at the time.
So you were a university professor, physician, and your own child was denied. Okay.
Yes. And so I think it was that kind of realization that if I can't figure this out, what do you expect the average American person to do? And I think, as you know, when you go through our system, getting an appointment today, is not so easy. Who you see is not so easy. And so then I was at Iowa for 14 years. I became a spine tumor surgeon. And of course, these are very complicated cases that I would see patients who often wouldn't get a diagnosis for 8 to 10 years after their symptoms started. And then they'd find out they had metastatic breast cancer. And I'd say, what's going on in this system? And so I realized that despite us seeing people when they walk in the office, there's a whole set of things that happen to them before we ever see them, if they can get to us. And nobody's kind of catching that part of the story. And then when I went to Dartmouth, we started something called the Dartmouth Atlas, which Jack Windberg, my predecessor, published the first paper in Science in 1974. He couldn't get it published in the New England Journal. He couldn't get it published in JAMA. It took years to get this, what I thought was groundbreaking work, showing the variation in care across our country. So this was an explanation to me of what, on a grand scale across the U.S., what was happening in each zip code. And I realized my story is just one of thousands, maybe millions. And so that really kind of, to answer your question, said, I've got to do something different.
And so thinking about that problem, what did you feel the proper solutions would be?
Well, first,
How do you begin to solve them? I guess that's a simple question.
yeah, I think the complexity is when you go through medical school, you learn the sciences, but you don't think about socioeconomics.
We don't teach the business of medicine.
No, we don't have the business of medicine, and not even the business of medicine, the business of the people we're caring for. When 40% of these of Americans can't even afford basic things, 40% in a country of 300 million people, that's a lot of people. And then you realize I don't see those people. They can't get to me. And yet that's a system that's kind of for the haves versus the have-nots. And so I took this very seriously because I feel, even today, that a lot of those populations are ignored. They don't have, kind of the whistle that anybody's listening to. We talk about diversity, equity, inclusion, and today, we kind of say those are bad words potentially. But the real bad words is ignoring. And so I take that very seriously.
So what you're really addressing is the underpinning for why there are disparities, and here you're alluding to access as being one of the issues for almost 40% of the population, and then some of your focus is on health equity. And so how do you begin to address some of those concerns?
So what I always say to people is geography is destiny.
Geography
Is destiny. So where you're born determines your lot in life.
So your zip code determines
what's going to happen to you. And we have to change that.
Expand on that for the uninitiated.
Yeah, so if you live in Mississippi, you have a very different lifespan than if you live in Boston. Even if you take Boston versus New Haven, the Harvard versus the Yale at the academic level, you're more likely to die if you live in Boston than if you live in New Haven. An important point there is they have more resources in Boston, more hospitals, more MRI scanners, more doctors than New Haven for the same size population. But having more doesn't mean better.
Access.
That's
Phenomenal. So one of the problems that we're going to have to solve, but we're going to put that in the parking lot for now, because I really want to ask about one other key point. And I know you focus on health equity a lot, but you've definitely been patient-centered. You introduced the concept of informed choice as a step beyond traditional informed consent. Can you tell us a little bit about what prompted this shift? And that clearly resonates quite well in today's conversations when we talk about patient empowerment, and particularly in the context of AI, because, we talk about Dr. Google, but the Dr. AI can just about help. And we're going to develop that theme a little bit. But please tell us about
let's just think of the doctrine of informed consent, which most patients and listeners are aware of. You sign a consent form to have your doctor do something. That doctrine is about assault legally. No doctor is trying to assault the patient. Okay? So that legal doctrine of assault, called informed consent, is misplaced. A doctrine of informed choice, where you allow patients to engage in the decision process, incorporating their preferences and values given best evidence, is a much better thought process and probably more realistic of what doctors and patients want to happen.
So it's an interesting, conundrum if you talk about informed consent presupposing assault as opposed to an informed choice. I've been at this now for decades, and I never quite figured that. And also I'm a surgeon, and we say, oh yeah, we get that informed consent, but that's truly revolutionary.
Yeah, I think when I've written about this because it shocked me that that's actually what we were having somebody sign something. I was never trying to assault my patients, but I wanted to share in the process of decision
making. I love it. So how did your early clinical experiences and research inform your approach to transforming healthcare and coming up with novel approaches such as informed choice?
Yeah, I think because I was a spine surgeon and because of my work on the Dartmouth Atlas, I thought there was a lot of overdiagnosis and overtreatment. Okay, so back pain is pretty common. The results of surgery are not so good. I've done the largest randomized trials on this in the country. So
tell us about that.
Yeah. So I did the SPORT trial, which means Spine Patient Outcomes Research Trial. And we studied the most common reasons for which people have surgery of their back: herniated disc, spinal stenosis, degenerative spondylolisthesis. And I said, let's take the most common things. Let's give them informed choice. Let's see who chooses surgery, who chooses randomization, because I allowed those who didn't randomize to also be followed with their choice, which is a big thing around understanding whether we actually need to do randomized trials. But the point is that what I found is, in most cases, I followed these patients for 10 years with NIH funding. The effects of surgery didn't have a great main effect compared to non-surgery. And tincture of time, regression to the mean, is really important. So people get better over time. And, in a lot of medicine, that's probably the case. If you have a cold and the doctor gives you antibiotics, it probably didn't matter. You were going to get better from that virus anyhow.
Over time.
But we tend to intervene because that's the incentive of the health system to get paid for doing something. I was more inclined to not get paid for not doing something, or have the patients appreciate the non-operative approach with a similar result and no scar.
The corollary, though, perhaps, is that when a patient goes to the doctor, they expect to have some form of treatment.
Yes.
And if you come out without having gotten anything, say, well, why did I come to you? Why did I pay you? Right? Is that in your research, does that contribute to the behavior that we see?
Of course.
Overtreat.
Yeah, so it's multifaceted, right? There are patients who, if I said no operation for your spine, they'll find somebody who will do the operation. But that doesn't mean it's right.
Exactly. Shifting a little bit to AI. So what initially sparked your interest in applying artificial intelligence to medicine to help solve some of those complex problems we're dealing with? And also tell us about how you ended up working at Microsoft Healthcare.
Yeah, so it's a good story. I think that I had developed a device with a watch before Apple, that we could monitor patients. So when I was a CEO at Dartmouth, we were spending $150 million a year on our employee health. I said, I think I can cut $10 million of that by following and if, that's money in our pocket as a healthcare system. It's important. So every dollar I save was a dollar to the bottom line. So we took our chronic ill employees with 2 or more comorbidities and said, would you wear this watch? And we'll just follow you. And if we see something wrong, we're going to reach out to you.
What specifically were you monitoring with that watch?
It depended on what they had. So blood pressure, respirations. We could understand from the tone of their voice whether they were depressed.
And you're getting all that information from the watch?
We had the watch, and we also had you might think of an airport air traffic control system. So all the data would come into our air traffic
Someone was monitoring everything.
Yes. And so it was funny because
were you eavesdropping on the patient? Was there any HIPAA violation there?
no HIPAA violations, but there were patients or employees who didn't want. It was all voluntary,
Of course.
and so we would have patients who had a history of high blood pressure, but when they were on their vacation, their blood pressure was low, and so we said, why are we treating their blood pressure? Because we have this white coat syndrome we were just talking about, where when they see that, but I think 30% of the patients were getting medication they didn't need. Just amazing stuff.
I mean, tremendous. So, okay, so you were a digital help before you
So
know how to spell it.
I built this on the Microsoft platform. Satya Nadella, who's just became the CEO, found out about it. He asked me to be a guest speaker at this global conference because we had this like air traffic control thing monitoring way before it became popular. Still isn't as popular today as it should be. And that's how I ended up at Microsoft.
Great. So we know that AI is widely being used in just about everything. Everything is AI. So let me talk a little bit about the study that you were involved with at Microsoft. In July, Microsoft released a report on the AI Diagnostic Orchestrator, which achieved an 85.5% accuracy rate, solving very challenging case proceedings from the New England Journal of Medicine. I must say, I get my New England Journal of Medicine journal regularly and look at those cases. Oh my gosh! But anyway, I'm just a pediatric surgeon. that notwithstanding, the accuracy for this diagnostic or AI diagnostic orchestrator was 85.5% compared to only 20% for a group of experienced physicians. Can you walk us through the design of the study and the capabilities of the AI system? Because this is truly powerful.
Yeah, there's lots of ways to think about this, and I'm just going to take a minute to. So first of all, it's remarkable, right? So when I first got involved with AI at Microsoft, I couldn't sleep because this thing was able to do things I just never thought were possible. And when you think of the future boardrooms or your future board, you might actually have an AI agent on your board because this paper had agents who took in information. When I say agent, it's an AI tool that specializes in a certain component of healthcare in this particular case. So there was an AI agent who had a hypothesis, presented the case from the New England Journal. Here's what I think is wrong. And then there's a challenging agent says, I'm not sure that's right.
So they are programmed to just essentially challenge or come up with theories.
Yeah, so don't forget, these are pretty unusual cases. AI has read everything, okay, AI per se. So it's not surprising that they could figure out something that nobody's read about, but they have.
That's the beauty
key
of an agent that focuses on hypothesis where it doesn't get all the diagnostic.
Yeah. But if you took a common back pain problem, which is common, that's a pretty common problem. But the nuances of, is that person working? Is there workers' comp and disability involved? Did they get hurt on the job? What's their signs and symptoms? That gets a lot more complicated.
So you need to integrate.
Yeah. These agents were taking very complicated cases that you've never heard of probably most of the time. I mean, that's the value of the New England Journal. They're teaching you, right? But then we had 5 agents. Like I said, one saying, what do you think's wrong? One challenging that. The most incredible part was looking at the cost part, saying, how do we do this most cost effectively?
Wow.
So it wasn't just that they got 85% correct. They did it cheaper, 80% cheaper than any other AI tool and 20% cheaper than any doctor. So as we get into healthcare, I wasn't kidding about your board. Who's going to be on your board in the future to answer questions? These tools are extremely powerful. And who do you want to ask? Maybe the board should ask Agent, Green. Could you help us figure this out today? Agent Green, you might consider this seriously. We'll have an answer for you. Now, your human part has to interpret whether, given our environment, that makes sense.
And to digress for a second, this is a fascinating concept. But when we talk about the hallucination, and then how do you begin to parse through some of that information to say, okay, well, this is what AI says we should do, but is it valid?
I think hallucinations is still a problem. And when we say hallucinations, we're talking about the wrong answer.
Right.
The thing here is that these agents are so good, they make it sound right. So you have to be careful as a medical student and as a practicing physician or as a consumer. This sounds so good. It sounds right. Doctor, why didn't you think of this? Well, I think a doctor who doesn't use AI in the future will be at risk because AI will become a partner, your best partner, into the future of practice.
So why do you think AI in this context, the diagnostic orchestrator, why did it perform better than the physicians? Just break it down.
Well, again, I go back to, if you've read everything in the world, these rare symptoms aren't rare to you. If as a doctor, you've never seen this before because you haven't read everything and you've never seen it, it's going to be hard for you to make that.
But even as a doctor, you may have read it en passant, and then it's in the deeper recesses of your brain, but you can bring it forward like AI can.
Yeah, I think that's right.
So how do you interpret the significance of this result in the context of real-world clinical practice? Should we substitute the primary care physician, with AI?
I don't think we should substitute, but I think the primary care physician should adopt AI and have it as a partner. I'm I couldn't be sure that in the future we will all have AI partners and collaborators.
So this is an example. At least the construct that you have here in the study was digital teamwork.
Yeah.
And is this what we need to embrace going forward?
I think so. We all have friends who've had, difficulty getting a diagnosis, and yet they're pretty, sick, and even at the best institutions in the country. And I know some very specific colleagues at top institutions in the country that have had their misdiagnosed illnesses, and they went to AI and found it. There's a famous case in the New York Times of a little boy, I think he was 5 years old, saw 17 doctors because he was in pain and couldn't walk. And his mother finally said, I'm going to ask GPT. And GPT came up with a diagnosis, which was tethered cord. A tethered cord affects, as you know, the spinal cord and your ability to walk. Surgery, fix. 17 doctors. Can you imagine the stress of that mother and that child for all those times not getting a diagnosis?
And we should say, at least for the audience, that the mother must have been well informed, because you have to put in the right set of questions or information in order to get this accurate interpretation.
I think the issue of how you prompt or how you use these tools becomes really important. And I'm sure the mother wasn't an expert, and I don't know her specifics of how she put information, but today you could put the child's x-ray report, the child's symptoms, and just based on if he had an MRI scan, they would see this piece of bone in the spinal canal. It would have made the diagnosis, because, in imaging, I think there's over 7,000 approved FDA imaging practices that use AI.
So how do you increase accessibility and say usability of this very powerful tool in healthcare? I mean, and what is Microsoft doing? No,
It's on your phone.
it's free.
It's free.
Okay, break it down.
Yeah, so I'm not advertising for Microsoft, okay, but I'll just suggest that if you take any of the current applications, GPT, Bing AI, Copilot 365, I'm sure Google, whatever, Grok, the Musk products, all of them have the ability now in the applications on your phone. You no longer even have to type. We could do it right here. You could ask a question here. I'll do it with you. So ask me a question. Just the one you ask.
Okay, I can't
Here,
remember.
I'll ask.
Okay, go for it.
So I'm using my phone here, and I'm talking to a bot, basically. And I have a question. Let me see. Yeah, so I'm talking to my friend here about how you work. And the question is, I have symptoms that are consistent with a medical condition called hypercholesterolemia. And I don't really know what to do because my doctor hasn't really given me good information. Can you help me?
Hypercholesterol. I'm here to chat and provide info, but I'm no replacement for a doc. Hypercholesterolemia is a mouthful, huh? It's all about high cholesterol, and the key is managing diet, exercise, and sometimes meds. Your doc should be your go-to for a plan. Maybe try another doc if you're not getting the support you need.
What are the risks if I don't treat it?
What are the risks of untreated hypercholesterolemia?
Sure thing. High cholesterol can lead to plaque buildup in your arteries, increasing the risk of heart disease, stroke, and other cardiovascular issues. Definitely a reason to stay on top of it and keep those levels in check.
What medications do you use to treat hypercholesterolemia?
Doctors often prescribe statins for hypercholesterolemia, like atorvastatin or simvastatin. Other options include cholesterol absorption inhibitors, bile acid sequestrants, PCSK9 inhibitors, and fibrates. The best treatment depends on your specific situation, so it's crucial to consult with your healthcare provider.
That is absolutely phenomenal.
And you can, everybody in the room here, I can share it. You can have it on your phone and it's free.
Wow.
So the problem is, one of the problems, you've seen some lawsuits because people use this for mental health advice. And it becomes kind of your go-to thing because it's there 24/7. So you do have to be, and it's not a hallucination issue, but we still need that doctor in the loop.
And so part of the danger is that if you overuse this and you become dependent on this partnership, there could be some adverse consequences, as we've seen some of the.
I think certain people are susceptible. We're not all.
Right.
But I think when you're desperate and you don't know where to turn and there's something available to you, you go to it. So I think we have to be careful.
So where do you see AI fitting in the healthcare going forward and medical education, and how should we prepare to embrace this powerful?
I think this is your major collaborator going forward. I could sit here right now and ask it to write a grant application for NIH with a specific hypothesis, some specific metrics of outputs that I want to get in there, and it would design the study for me. I could give it all of your student applications for medical school and say, could you pick out what you think are the best and why? So it's quite interesting how you use this. I've become quite good at using it as best I can. But I also think, and I want this to be understood, that humans can adapt at a certain rate. If you have an XY plot and you're looking at how humans adapt to it, there's kind of a slope up. But these things are going so much faster than humans. So we can't keep up with this. And the risk is, what do I trust? What do I not trust? Who in my team is using these things? Is it really their work? Is there a mistake here? There are legal cases where lawyers have used this and misrepresented case law because they didn't look it up. Bad on the lawyer. How could you not look it up? In medicine, you can't make a mistake with a patient's treatment because you trusted a tool. You have to understand, because you're liable as a doctor, and what will the future liability look like? But I think these tools are essential partners.
This is great. I think I always like to say moderation in everything, including moderation itself. Yes, this is a powerful adjunct, but you still have to use it wisely.
Yes.
The final question, because there's so much more I could delve into, but how does this powerful tool either improve or diminish our attempt to solve for health disparities and promote health equity?
I think that's one of my key areas of interest, as you know. And I have a fear, which you may have heard me talk about, that technology tends to improve GDP almost in an exponential, back to the printing press, to the iPhone, and now AI. GDP's going like this. My fear is it will also widen the disparities between the haves and have-nots. The reason I wanted to demonstrate for you, because almost everybody has a phone. If you use this, everybody, it allows that ability to kind of negate that disparity potentially. But you have to be able to understand what you're hearing and how to use it. So I'm hoping it becomes a tool to narrow the disparities. But I'm uncertain that's true. I think that's on us. How do we do it?
And making sure that everyone has access and is well versed in how to
Yes.
utilize this. What a fascinating exchange this morning. I am absolutely thrilled to have had this opportunity to hold this conversation. Honestly, I could keep going for hours, because you are such an amazing storyteller and have a wealth of information to share with the audience. So thank you for taking the time to educate us this morning and demonstrate the powerful tool that we have in our hands.
It's a pleasure to be with you, and thank you for all you do too. Appreciate it.
Dr. Weinstein, keep shining and keep thriving, and we look forward. I didn't even get a chance to ask you, but we look forward to your next book.
Yes.
And maybe one sentence about what it's all about.
So my next book is called The Hub and Spoke, Patient Empowerment, to our point. And I use the analogy of a tandem bicycle. In this case, the patient is on the front steering, and the doctor's on the back pedaling. And the patient leads where we're going with healthcare. And we keep the hubs and spokes in the tandem bicycle where they're both pedaling, is the operating system so we always stay on the same page.
I can't wait to get a copy of that book. So,
Yeah.
so thank you so very much, and thank you for all your contributions on healthcare.
Thank you.
And this has been another fascinating episode of Inside You Miami Medicine with the phenomenal Jim Weinstein from Microsoft Healthcare. Thank you so very much.